Thank you very much, Claudius. I'm more than happy to take part again in your webinars. I will always admire your work, and I have prepared a short presentation on genetic background. I hope you will see my screen. Can you see it?
Yes, we can see your screen.
Perfect. Genetic background of fetal growth restriction. It is well known that the smaller you are, the higher the risk of severe complications, even death. Isolated fetal growth restriction is associated with placental disease, which can be isolated or part of confined placental mosaics. Fetal disease, which can be either part of genetic syndrome or epigenetics, or infection, and of course the maternal factors, extreme maternal age, toxic exposure, and maternal disease. It is of crucial importance to take maternal history when you investigate a normally grown fetus. Smoking is a very well-known risk factor for smallness, past history of preeclampsia, autoimmune condition, body mass index, diabetes, maternal height and head circumference. Small-headed parents give birth to small-headed children. Maternal illness, maternal exposure to different toxins, previous obstetric history. We have to know the size of the previous baby if there was a history of miscarriages. In the first trimester, dating is by definition done by CRL, and growth retarded fetuses are missed unless they are twins or IVF. Some women are certain of their dates, so we need to keep that in mind when we investigate the baby. Some doctors bring the patients again at 16 weeks when they have suspicion of some condition. However, the scan with the most clinical importance is the 20-week scan. We have to check the dates from the first trimester, check the biochemistry from the first trimester. Low PAPA is associated with smallness, screening for preeclampsia in the first trimester if the patient was on aspirin, to perform the full anomaly scan, and of course the Doppler studies. Low PAPA is associated with chromosomal abnormality, trisomy 13, 18, triploidy, and trisomy 16, placental insufficiency, and Cornelia de Lange syndrome. The majority of the world experts agree that the definition of fetal growth restriction should exclude congenital or genetic anomalies. One study by Professor Nicolaides in the early 90s revealed that in more than 400 cases of severe early onset fetal growth restriction below the third centile, in 19% of these cases there were genetic syndromes. If the amniotic fluid was normal or if there were polyhydramnios, 40% had genetic syndromes and oligohydramnios 8%. The genetic conditions that we should be aware of include the chromosomal anomalies, submicroscopic anomalies, and single gene disorders. The analyses that we have access to are the QF-PCR, which can pick up triploidy, trisomy 13 and 18, RACGH, which will miss triploidy, will not be identified, and the newly introduced in the clinical setting whole exome and whole genome sequencing. However, we don't have universal access to these tests. Amniocentesis will miss confined placental mosaics. The most common chromosomal anomalies that we see in the first trimester are trisomy 18, 13, and triploidy. They are associated also with fetal growth restriction. However, these conditions, they have major defects. And let me show you an interesting case. Nothing special from the first trimester except for the ductus venosus agenesis. Patient was offered and she declined invasive testing in the first trimester. However, in the second trimester, we have seen VSD, progressive growth restriction, and microcephaly. We offered invasive testing, she accepted it, and the test revealed 29% mosaics of trisomy 13. With the fetal mosaics, we should know that the well-known syndromes are presented with mildly expressed signs that aggravate with the development of the fetus, and serial scans are of crucial importance to make the diagnosis. Placental mosaics that cause fetal growth restriction are chromosome-specific, and not all chromosomes cause fetal growth restriction. The most common is trisomy 16. QF-PCR can pick up if it is mitotic or meiotic confined placental mosaics. Sometimes it can be caused by uniparental disomy. For the uniparental disomy, the most common are trisomy 2, 7, 9, and 15, less likely trisomy 16. But we have to know this part of inheritance as well. Confined placental mosaics may cause 20% of idiopathic fetal growth restriction. It will be missed on amniocentesis, and the cardio of the placenta is not performed. The application of chromosomal microarray analysis in the prenatal diagnosis of fetal growth restriction, I think, is a must. And here you can see in this study that in the cases of fetal growth restriction with normal anatomy and normal karyotype, the abnormal microarray was found in 11% of the cases. A study by Anthony Borel revealed that the microarray will increase the detection rate with 4% in the normal anatomy cases and with 10% in the cases with malformations. And now let me give you different scenarios with symmetrical and asymmetrical fetal growth restriction and how the clinical picture could lead us to the diagnosis. Symmetrical fetal growth restriction and normal microarray. It can be either placental insufficiency, infection, or genetic syndromes. We are like detectives. Prenatal diagnosis is difficult due to the heterogeneous expression and rather non-specific ultrasound findings. Sometimes, Cornelia de Lange syndrome, for example, with very well-known facial and limb abnormalities, can be presented only with growth restriction. The same is with Bowe-Hirschhorn syndrome. I had 2 cases with normal NIFTY-PRO, non-invasive prenatal testing, and later on, we've confirmed with amniocentesis Bowe-Hirschhorn syndrome. Asymmetric growth restriction and small head. This is the most worrying type of fetal growth restriction. What we should do is to measure the parental head circumference, perform amniocentesis, bring the patient back in 2 weeks to check the growth velocity of the head, and offer 3rd trimester fetal MRI if all come normal. And this is a case of mine, a 40-year-old patient that came at 16 weeks and requested amniocentesis. The karyotype came back normal. She came back again at 37 weeks and growth restriction was revealed with small head. After the delivery, Niemann syndrome was confirmed. Asymmetric growth restriction and short femur. It is associated with Down syndrome. Early onset placental insufficiency, it can be the first sign of skeletal dysplasia. So what we should do is always to check the fetal and maternal Dopplers to exclude placental insufficiency. We should do the full anomaly scan, check the long bones, check for polydactyly, and investigate the growth pattern. And this is a case of a 20-year-old woman. You can see even from the first trimester that there is asymmetrical growth. Also, from the dates, based on the last menstrual period, she was supposed to be 12 weeks and 4 days. However, the CRL showed 10 weeks and 6 days. There was low risk from the first trimester. I told in the beginning it is triploidy. We offered invasive testing. She declined. She came back at 20 weeks. The asymmetric growth was progressed. We did back then amniocentesis. The chromoset came back as normal. Then we add additional panel for Silver Russell, and it was confirmed. Another case with third trimester fetal growth restriction, polyhydramnios, and reduced fetal movements. Prader-Willi syndrome was confirmed after the delivery. In conclusion, fetal and neonatal genetic testing appears to be crucial in the early onset fetal growth restriction. Most genetic disorders are caused by de novo variants, and some may be inherited. Serial detailed ultrasound scans should be performed to assess the new findings that can help us in the diagnosis of monogenic disorders. And I thank you for your that the smaller you are, the higher the risk of severe complications.